Okay, so our topic is all about endoscopy and colonoscopy. And once again, I'm Ronald Mbiine. I'm a surgeon in Mulago on the gastrointestinal surgical unit. And I'm also an endoscopist and laparoscopic surgeon. I'm also a lecturer at Makerere. So endoscopy broadly is a practice or a procedure that is used to look inside any body organ or cavity within the body. The word endoscopy comes from two words, if I may say. There is endo, which means internal or inside, and then scopy or scope, which means to see, to investigate, to look around. And broadly, any cavity in the body can actually be scoped. So you can perform an endoscopy in any part of the, any hollow part of the body. For example, you can have an arthroscopy, which is endoscopy of the knee joint. You can have a bronchoscopy, which is endoscopy of the lungs. You can have a colonoscopy. You can have an upper gastrointestinal endoscopy. You can have a cystoscopy where you look inside the bladder. So an endoscope is a medical device. It's a long rubber tube. It's flexible, and it has a camera and a light source attached to its end. And within it, it has a complex mechanism of optic fibers, cables that enable someone, the operator, to manipulate it to be able to navigate through the cavities. And like you see in those images, there's a handpiece or the control arm, which has wheels that are used to navigate the tube. And at the center, you can see the tube, which actually can bend and easily move through the cavities of interest. And then the image here, you can see the camera. I hope you can see my cursor. And then you see the light sources, the torch, the sources of light. And then there is another opening here, which is a channel that we use to perform any intervention. So the image you see below is actually of a healthcare practitioner performing an endoscopy. And you can see the movements, the hand, the control arm, and the insertion point of the endoscopy. A brief history of endoscopy. It's not been all rosy like it is right now. When you stop to imagine what endoscopy was just a century ago, it's almost unimaginable. In the first image, you can see what you see there is what's called a rigid endoscope. So before Basil, endoscopy was a rigid metallic tube. It looked like a sword. It actually looked like one of those magic tricks. Unfortunately, that the patient wasn't part of the magical team, if I may say. So the patient would have to straighten their neck, and the whole rigid scope as it looks would be inserted. Of course, you can imagine the trauma that was associated with this kind of procedure. In those days, if you were sick and you saw, they told you that they were calling in a physician, and the physician came holding a long, rigid structure like you see in the middle picture, that's how you got to know that you are going to have an endoscopy. And it was not a very good experience. The last image you can still see looks like a torture, one of those torturing, processes done by some of the armed forces. But in actual sense, this was an endoscopy being performed by medical workers. Thanks to Antonin, Jean Dissot, and Basil, these are the two guys who fundamentally changed the practice of endoscopy. Antonin invented the first scope, which was a lot more medical and had more therapeutic potential. And then Basil is the gentleman you see at the center in a white clinical coat. In the lower image on the left, it's the same person performing an endoscopy. And Basil is credited for having invented the flexible endoscope. And thanks to that gentleman, you see medical practice has significantly changed. Endoscopy is one of the marvels of one of the technological marvels, actually, even to this date. And simple as the instruments look, there is a lot of science that has actually gone into developing them, thanks to gentlemen like those. So the scope, the setup, the endoscope is what you see in the green background. So the flexible long tube is what is coiled there. And then the control arm is up here. And then the other tube connects to the machine. At the center, this is the machine that has the energy source, the processor, the light source, and all the other components of endoscopy. And then on the right, that is a typical setup for the endoscopy room. This procedure is not typically done in theater, so it's more of a daycare procedure. So you should be able to access it in a room that looks such as those. Getting back to gastrointestinal endoscopy, which is the topic of interest today, it can be either an upper gastrointestinal endoscopy, what we routinely call endoscopy. So most of the times, endoscopy tends to refer to the upper gastrointestinal endoscopy. And then it can also be a lower gastrointestinal endoscopy, and that is what we call the colonoscopy. For the upper gastrointestinal endoscopy, the tube, the flexible rubber tube that I told you about, that you see someone holding, is actually passed through the mouth. And then evaluation or examination started in the mouth. We look at the throat, we look at the esophagus, we look at the sphincter, that's the gastroesophageal junction sphincter. We look at the stomach and also the first part of the small intestine that we refer to as the duodenum. And like you can see in the other image, the tube passes all the way to those parts with the camera, and we are in position to see. For the colonoscopy, on the other hand, the tube is passed through the anal canal. So like you can see in that image, the patient is lying on their side, and then the operator has passed the scope, the colonoscope, through the anal canal, and they've inserted it into the colon. So for the colonoscopy, it's used to evaluate the colon, and the colon has all these parts: the rectum, the sigmoid colon, the descending, transverse, ascending, and cecum. In some instances, you can use the colonoscope to visualize or to look into the last bit of the small intestine, what we call the terminal ileum. So why do we have to have this procedure done, uncomfortable as it looks? First, I need to mention that endoscopy has significantly transformed the management of gastrointestinal diseases. So we need to thank God that there is a modality such as this, because without endoscopy, medical care of gastrointestinal diseases is completely blind. So you're going to have people presenting with the most advanced form of diseases. But with a simple procedure as endoscopy, we've completely turned the tide of gastrointestinal care. So we do endoscopy, one, to screen, what we call a screening endoscopy. It's also called a surveillance endoscopy. So occasionally when you hear someone saying, I want to have a screening endoscopy, that's one component. We also have what's called a diagnostic endoscopy. Now that one is used to find causes of symptoms that people might have. We also have what's called a therapeutic endoscopy, and that is an endoscopy done to treat a disease condition. And we are going to see some of these. The screening endoscopy is performed in an otherwise healthy individual. So in some countries like Japan, because they were found to have a higher prevalence of cancer of the stomach, they have a policy that any person that is above the age of 45 has to have a screening endoscopy, regardless of whether they have any symptoms or not. So the aim of this is to look for diseases that could silently be developing and easily missed. So here locally in Uganda, we recommend screening endoscopies for people who we refer to as being high risk for developing some of these cancers. For example, if you have a first-degree relative, if your brother, sister, parent have had, let's say, cancer of the colon or cancer of the stomach, there is a certain degree of risk because you share the same genetic component. There's a certain degree of risk of you developing cancer, the same cancer. So in people like those, we recommend that we actually have a screening endoscopy. There are other particular instances where we may recommend a screening endoscopy. Some people who have had, let's say, history of smoking, who have been working in radiation, places that have high radiation, let's say X-ray, people who operate X-ray machines. And things of that nature. Sometimes we might recommend that they routinely yeah, so basically that's what we refer to as a screening endoscopy. So why is screening important? If you look at this picture, so all cancers actually follow the same pattern as the picture you see there. You start with a very tiny little swelling, we often call a polyp. It's as small as a pimple, yeah? And that can be there for 5 years when it's just quiet and latent. You know, it's not posing any serious threat to you. And then that progressively develops, it enlarges gradually until when finally it forms a cancerous growth. So this one, medically, we call it the adenoma carcinoma sequence. And basically what that is the whole sort of life process of cancer developing in the gastrointestinal tract. So when we screen, this presents an opportunity for us to catch cancer at a very early stage. Because if you got cancer, if you see all these images, 1, 2, 3, 4, 5, 6, all these cancers can be cured except the 6th one, this one where you see invasive cancer. But all the rest can actually be cured endoscopically without having to do surgery. And someone is actually cured for the rest of their life. Once you have what's called the invasive cancer, it means that now the cancer started invading beyond the original point. Then there are those are the instances where it's a lot more difficult to treat. The interesting bit is that all this is a process that can easily be picked at screening, and someone is actually cured of cancer. So next is the diagnostic endoscopy. Remember, the other one is screening in someone who completely has no symptoms. Now, there are other instances where someone actually has symptoms. Someone has abdominal pain, you know, they have all these symptoms like you are going to see. And now they come seeking care. Most often, this is a request that's made by the treating healthcare provider based on the nature of symptoms that the presenting person has. So what are the nature of symptoms that often will require your physician or primary healthcare provider to request you to have an endoscopy? Now we are looking at the upper gastrointestinal endoscopy. One of the commonest symptoms we are seeing is difficulty in swallowing. Medically, we call this dysphagia, and it takes on a spectrum. It can be choking while eating food. Someone mentions, every time I eat food, I feel it's choking me. Sometimes it's actually coughing after swallowing. So someone swallows food and they start choking, yeah? In other instances, someone eats food and they vomit their food. So the food fails to advance down into the stomach. Sometimes the voice may actually change. Other times they eat food, and especially when they go to sleep, the food goes back and enters their airway and they aspirate. So all these, we broadly classify this as difficulty in swallowing. And this can be some of the symptoms that are trying to show you that, look, there is a problem going on. And it's one of the commonest reasons that a primary care provider might request for an endoscopy. There are quite a number of causes that can cause someone to have challenges swallowing. Sometimes there is a physical structure that's growing and blocking, which could be a cancer, it may not be a cancer. Other instances, the sphincters are very tight. Medically, we call that achalasia. Other times, there is complete disorder of the flow of what we call peristalsis, that the esophagus doesn't propel the food bolus down into the stomach. And with endoscopy, you can actually be able to identify what the cause is and also enable appropriate intervention. Other times, it may not be difficult in swallowing, but there might be symptoms, which sometimes we call acid reflux symptoms. I tend to see quite a lot of this. Someone has bloating, someone has a sensation of a food particle in their throat. So they will come to you and tell you, Musawa, I feel there is something like a potato in my throat. Other instances, they will tell you, after I've eaten food, the food comes back. I feel like I'm chewing cud, you know? So all those are symptoms that are actually showing you that there's something going on that needs to be looked at, yeah? In case you continuously are getting sore throats, you know, you're always having a sore throat. Oh my God, I have a sore throat. These dry coughs that never seem to heal, hiccups, nausea, you know, burping, we also call it belching. You encounter people who will say, every time I keep having belching. All these are signs and symptoms that there could be something going on, particularly in the upper gastrointestinal tract. And these are some of the symptoms that your physician might request you to have an endoscopy. The other symptoms, this is also pretty common, is pain, epigastric pain. Medically, we call this dyspepsia, but that is just sounding fancy. But what it means is that epigastric pain that in Uganda we call ulcers in Numa. Yeah, so that epigastric pain, it can be burning in nature. Someone might tell you, I feel like I have a wound, you know, in my belly, you know, the fullness, bloating. So we broadly classify all those symptoms into dyspepsia. Now, it doesn't mean that if you get that pain, you have to have an endoscopy. But there are instances where you have the pain, you've sought care, you've been treated, and there's actually no improvement to the regular medicine. Now, that is a sign that there could be something bigger or greater than what you think you have. And more often than not, we request that we have an endoscopy and look there to confirm. Some of the other reasons, and this one we tend to call them alarm signs. Bleeding. So when you have bleeding, vomiting blood, and this one varies. It could be small amounts of blood, or it could be what we call massive hematemesis, a lot of blood being vomited. Once this is seen, you actually shouldn't stay home with symptoms like this, because it could result in life-threatening effects on you. Yeah, so we always recommend that if there is bleeding, and if you see a primary care physician, they will actually request that you have an endoscopy. And the causes of bleeding are quite a number, much as this presentation is not directed to go into those details. A normal endoscopy will look at the mouth, like I told you. We'll look at what we call the hypopharynx. This is the area that has the vocal cord. We'll evaluate that whole place. We'll look at the esophagus. The first image is showing you how the esophagus looks like on endoscopy. And you can see these are high definition, they are clear photographs. They really give you all the detail that you need. The stomach, the second and third images are actually showing you the stomach. And then the fourth image is showing you how the intestine would look like. Of course, the person performing the endoscopy has the technical ability to see what disease processes are there. So if there are wounds, if there are growths, if there is anything that is not normal, they will be able to identify that. So next is colonoscopy. Just 1 second. Yeah, so we've been looking at diagnostic endoscopy. So now we are looking at when to have a diagnostic colonoscopy. Of course, most of the times, like I told you, you will have sought care from a physician who will recommend that you have this test. But there are symptoms which, if you develop, you definitely have to seek care. Bleeding is the commonest, and this takes on quite a number of forms. It could be what we call fresh blood, and often people will tell you that after going to the toilet, I see blood dropping or dripping. Other times the blood is mixed with the stool. Other times the blood has taken on a dark color, black or coffee brown. All these are indications that there's bleeding within the colon. You remember I showed you the picture of what the colon is. So once there is evidence of bleeding in the colon, that has to be addressed urgently. Of course, the primary treating doctor would advise on quite a number of tests that can be done. Like I mentioned, for colonoscopy, you can still have a screening or surveillance colonoscopy done in individuals who are actually healthy without any symptoms. Sometimes we might have to do a test called the fecal occult blood test. You don't have to know all the details of that, but we look at the stool sample microscopically for evidence of blood. So sometimes there might be microscopic blood, which cannot be seen with the naked eye. And in case there is evidence of microscopic blood, then we would still have to ask for a colonoscopy. There are quite a number of causes for causes of rectal bleeding, including hemorrhoids. Those are the piles most of you have heard about. Sometimes there are wounds in the rectum and colon. Sometimes there are conditions we call inflammatory bowel disease. Luckily, all that is for your doctor to handle. You don't have to know all those details. But also, most importantly, we want to make sure there is no cancer, because if cancer is not caught early, you can easily lose time, opportunity to cure someone. Other diseases include diverticular disease, fissure in ano. There are infections that can happen within the colon, polyps, and a number of other conditions. Just 1 second. Okay, so the other times that you might, the person treating you might request you to have a colonoscopy is if you have chronic diarrhea that does not seem to heal. Most of the times, diarrhea is meant to clean or rid of the body of an insulting sort of agent, yeah, or bacteria. But if the diarrhea remains for long, especially more than 2 weeks, some people have diarrhea for months and years. That is a signal that there's something going on and something that needs to be further assessed. Yeah, there are diseases that you've heard about, IBD. You might have heard of diseases like Crohn's disease, ulcerative colitis, and these can cause chronic diarrhea. If these are not investigated early, you might miss an opportunity to have them treated, controlled, and then they might manifest with all the other complications that come with them. We also do colonoscopy for severe constipation. Sometimes the constipation is due to something obstructing the passage of the stool. And then you've taken all these medicines, they are not helping you. So your doctor might actually request you to have a colonoscopy done. In other instances, abdominal pains happen and they vary depending on the site and site, but the treating physician might see it necessary to have you do a colonoscopy. While in other times, we may find something suspicious in the colon, let's say on CT scan or ultrasound scan, and then you're asked to further evaluate that using a colonoscopy. So this is an image of how a colon looks like on colonoscopy. It doesn't look as bad as most people would expect. Like here, you can see it's a nice clean colon because we've given the person medicine to clean that colon. And you can see that you can be able to visualize even a tiny, small swelling, what we call polyps. Yeah, so I don't want to share pictures that have scary diseases, so I'll only share that is normal. But at least with the colonoscopy, we are able to capture most of the colon diseases. Now, there's something called biopsy. Most of the times patients get jittery when they hear this word, akanyama. So from time immemorial, there's been quite a number of perceptions and myths about biopsies. And we tend to see the fears expressed also when we are planning to do these endoscopies. Well, what we do is a forceps is passed through the endoscope. You remember I showed you a hole or an opening. So this is a diagram or a picture just stipulating how a biopsy is done. The black you see is the scope. These white areas, those are the torches that are illuminating the colon. So the colon without the endoscope light, it's a dark place that you can hardly see anything. So when you flash the torch of the endoscope, you can actually visualize. And now you can see this device here is the biopsy forceps. So it's been pushed through the scope and opened and used to pick a sample of tissue. In the other image, you can see the actual photo of the wire. And here in image B on the right, you can see the forceps is actually picking a bit of of tissue. I think maybe at some point at the end, members can raise some of the fears and myths about biopsy, but presently there is no evidence that taking biopsies makes any disease worse. Most of these have been there for years. And also the bites are really small. They cannot perforate through the intestine to go to the other bits of outside the lumen of the intestine. So once the samples are taken, they are extracted and sent to the lab, to a pathologist who usually looks at them, and they tell us the nature of cells within the specimen that we've taken. Usually we do this when we see suspicious lesion, something that may look cancerous, or some disease that we may feel will need more details from the pathologist. The other bit of endoscopy, you remember we looked at the screening, we've looked at the diagnostic endoscopy, and now we are looking at the therapeutic. So thanks to endoscopy, not all colon and gastrointestinal diseases actually need surgery. So increasingly, endoscopy is being utilized to treat gastrointestinal diseases. But there's a catch that the diseases have to be caught early through endoscopy. So you do an endoscopy, you find there's a growth in the colon. About 10 years ago, this growth would have been missed, and it would have grown so big to block the colon, and then someone would present to the hospital in an advanced stage. Luckily for endoscopy, this is a lesion that is picked very easily during either the screening or diagnostic endoscopy. And once this is picked, it's actually cut out through a procedure called polypectomy. Here you can see this device. It's a snare. It's used to cut that polyp out and extract. So like you can see there, the snare has been launched. In the image B, the snare has been used to cut, and image C, you see that the polyp is completely off. Now, simple as this looks, it has actually turned around the incidence of colorectal cancer in some of these developed countries. By that I mean, because these therapies are available, people no longer present with cancer of the colon. Well, not that they no longer present, but the number has drastically gone down. And the reason is because this is being picked up. In Uganda, we're also trying to push for making colonoscopy as widely accessible to all, but of course there are limitations. Because all people who develop cancer of the colon actually start here. They start with a swelling as small as that can easily be picked at colonoscopy, and they are cured. Yeah. The other therapeutic procedure, this one is a little bit more advanced, and we do it for bigger tumors, and we call it endoscopic submucosal dissection, or ESD. So this one still, once we find a bigger, you remember the other one was a polyp. A polyp is a very early tumor. Now here we find, if you look at image A, we find an actual tumor that has grown. And then we can actually, using still endoscopic technology, be able to cut or resect this tumor. In the second photograph that you see on your right, you can see that the tumor has been flipped and a plane has been developed under that. So once again, this is someone who had actually cancer of the stomach, and they've been cured by merely cutting that out endoscopically. So these are technologies that can be harnessed. They seem expensive at the start, but when you look at the cost of performing this procedure vis-a-vis the cost of having to take care of someone with an advanced disease, this is way cheaper. This one has a bit of blood. Forgive me if there's too much blood on the screen, but we also use endoscopy to control bleeding. So there are people you probably have heard about that they are vomiting a lot of blood, and they are losing so much blood. So you can still use an endoscope, go find the bleeding point. And if you look at the first images on the left, you see there's so much blood in the first image. The second image, there are some funny looking structures. Those are called clips. Now, those clips have been used to clip the bleeding vessel. And now this person's life has been saved just by doing that. In the old days, someone had to cut someone's belly wide open, go and put their hands in there, grab a lot of things. And this can be done, a 5-minute procedure, and someone's life is saved. On the right, there's something called esophageal stenting. Once again, some of these diseases block, because remember, the gastrointestinal tract is a tubular structure and it's transmitting food. So sometimes because of different growths, they can grow into the lumen, the tube of the tract, and obstruct it. So in such instances, like you can see there is a square with cancer, you can actually launch what's called a stent. A stent is that mesh-like structure you see there, and you put it within the tubular structure, and it prevents the growth from completely occluding that tract. This is something done with for people who have advanced diseases that cannot be operated. But at least when a stent is in place, they can continue to feed and eat. The lower image is an actual stent that has been launched into someone. Now, endoscopy is a minimally invasive or minimally intrusive. We minimally enter without necessarily cutting open the person that is having this procedure. Often, you're going to have to sign a consent form. And with consent, this is called informed consent. So basically, it means one, you've been told what's going to be done. You've actually understood what's going to be done. You accept it. And the person who's going to conduct the procedure will explain each and every step if they take you through the procedure. There are instances where someone might, after having the endoscopy, they tell you, me, I thought you're going to remove my tooth. Now you looked into my stomach. So it sounds like a joke, but people really need to understand what they are going to have. And then they should have an opportunity to ask questions. So if you're a patient, the doctor should actually fully explain what's going to be done, and then you get an opportunity to ask questions. The procedure preparation, this is a lot of people ask questions about this. For the upper GI endoscopy, there is not much that needs to be done, except that you fast overnight. So basically what that means is after taking supper, you go for the procedure without taking breakfast. This is very important. Like you saw the images I showed you of the normal stomach. You didn't see porridge, chicken, beef, and all that. Because if you go in without appropriate preparation, you're actually going to find food and you'll miss the actual disease that you want to get. For the colonoscopy, we do what's called bowel preparation or bowel cleansing. So we give medicine that gives fairly some severe diarrhea just over a span of 6 to 8 hours. And then I hope you remember seeing how clean the colon looked. So the medicine actually washes all the stool out, and the procedure is done. If the bowel preparation is not done, it's not a very good experience, both for the patient and for the surgeon providing. Most of the questions people ask actually about this: is it painful? Most of the patients I see come with all these preconceived ideas. A few years ago, endoscopy was done what we call non-sedatively. Non-sedatively means you basically lie on the bed and the procedure is performed when you're fully conscious and aware of what's happening. Progressively, as time goes on, we are adapting better sedative practices. And basically what that means is that we give you medicine that puts you to sleep. So you have no memory whatsoever of the procedure, and it's generally an enjoyable experience, both for you and the endoscopist. You don't want to imagine a situation where the endoscopy is being done and the doctor is fighting, the patient is fighting, So that's how it was done in the old days, but now at least most centers are adopting a sedative practice. The medicine that's given is a very short-acting drug, so usually it's about 5 to 10 minutes, and by the end of the procedure, you're actually fully awake, and you can walk out of endoscopy room. Of course, we don't advise that you drive or operate any machinery after the sedative medicine, but at least you should be able to be fully conscious. And immediately after that, you can take your meals, you can eat your food comfortably. Endoscopy is not an in-hospital procedure, so it means you get to the place, have it, go back home, without having to be admitted. This is where questions also tend to come, at least most of the times when I get questions. Complications. I always tell my patients that endoscopy is generally safer than the transport means they've used to come for the endoscopy. So you're probably more likely to die from a border accident than the endoscopy procedure. But nevertheless, there's always a risk, just like taking a flight, there's always a risk. Most of the complications from endoscopy actually come from either sedation practices where patients get to have more drug that they need, or sometimes the centers may not have the SOPs to pick and identify complications. Most of the times you need to know that the patient is fit for the endoscopy. For example, in some instances, there are people we turn down, what we call contraindications. Like last, I think a day or two ago, someone was brought in for an endoscopy and they had challenges breathing. They could not sustain their breathing. And then we had to say, okay, is it the endoscopy or fixing the breathing, which is the most primary or urgent, item to take care of. So patient selection is critical. Yeah, so an endoscopy, unless someone is bleeding, is not an emergency. So if someone can't breathe, they have a pneumonia, they have a seizure. A seizure is a convulsion, they're having a convulsion. That's not the kind of person who needs an endoscopy. They can actually be fully stabilized and then the procedure is done. Some instances, there are complications, for example, where someone has a disease that is joining the esophagus to the trachea. And then, already that compromises the ability of the person to manage to tolerate the procedure. Other complications that have been documented include injury to the bowel or the intestine. And these ones may depend on the technical experience of the person providing the endoscopy. If you're having the endoscopy done in a high volume center, and that is a center that is continuously performing these endoscopies, it's less likely to this to happen. But if you're in a center where someone does one endoscopy in 3 months, then we tend to see complications happening at a higher rate. For procedures like I showed you, where you have to cut a tumor out endoscopically, we admit the patient and observe them. Endoscopy, also, if standard operating procedures are not followed, can be a conduit for infection. If the endoscope is not appropriately cleaned, there's something we call high-level disinfection. Because those tubes are rubber, you cannot cook them, what we call autoclaving. So we use chemicals, specific chemicals that clean and destroy any bacteria, any DNA of any organism, but also the technical capacity of the people cleaning them, their expertise is very important. And if a center is not adhering to very high levels of sterility, there's a risk that infections can actually be transmitted through this procedure. Now, there are newer technologies. This is occasionally I also get people asking me, is there another way that this can be done without putting a tube down my throat? This technology is called capsular or capsule endoscopy. So what you see the lady holding is a capsule that has a camera in it, a light source, and has the capacity to record and relay information to an external device. So someone swallows it and then it takes on its course. Of course, this is a technology that's been around. It's greatly limited by quite a number of things, For example, if you see the camera is front facing, the camera is on one side. So it means if peristalsis turns the pill the other way, then you can potentially miss a lesion. And then also, if you saw something and didn't see it clearly, you can't say, let me first go back and see. So because of that, it has significantly not been adapted. Of course, it's very expensive, yeah. But these are some of the technologies that are developing that can be used in endoscopy. I try to keep my presentation short, but I have a very interesting statement here that colonoscopy is important. It helps the doctors to get to the bottom of the issue. Thank you.